Well, hello, everyone. My name is Rhonda Fisher, and I am the clinical program lead for team training at the American Hospital Association. And we are so glad that you've chosen to spend a portion of your day with us today for today's sponsored webinar, The New Approach to Mitigating Clostridium difficile, or C. diff, as those of us who are clinical so affectionately call it through the years. So, new approach to mitigating Clostridium difficile transmission while saving direct cost to the hospital. We're extremely honored to have Ecolab sponsor and lead this presentation and discussion today. We appreciate their leadership and the work they've done in this super important area. So before we get started, just a few rules of engagement to highlight. You can access audio by listening in through your computer speakers or through your phone. Please note that you're in a listen-only mode. If you're having issues, you should be able to access the toolbar at the bottom to switch to either phone audio or computer audio throughout the presentation. This webinar is being recorded, and we will make that available on our website. The slides were sent via email this morning, but we'll also share those in the chat so you've got quick access. Throughout the webinar, if you have any other questions for our speakers, please enter them in the Q&A pod, which you can find at the bottom of your screen in the Zoom toolbar. Sometimes people get confused and put those into the chat. We'll try and look for them there as well, but do be aware that there is the Q&A pod, and that's where we'd love to see those questions come through. I will be doing a moderated Q&A session at the end with our panelists. If you have any technical questions or comments in general, do feel free to use the chat pod for that. Please note that all participants on the webinar can view the chat pod, but it won't be included in the recording. Finally, after our webinar is over today, we'll have an evaluation that will pop up on your browser. We really value your feedback, so please do take a moment to complete that for our speakers and for us here at the AHA. So with that, it is my great pleasure to introduce our speakers today. Philip C. Carling, MD. He is the Director of Infectious Diseases and Hospital Epidemiology at Kearney Hospital in the Dorchester area of Boston. He teaches and is involved in clinical research at Boston University School of Medicine, where he's a professor of clinical medicine. And Dr. Carling's research activities have primarily related to developing processes to evaluate and improve patient area surface disinfection cleaning and translational research related to the role of wastewater drains in hospital-acquired infections. Also joining us is Billy Fisher. He is the Regional Director of Operations for Environmental Services and Laundry Linen Services and Transportation for Trinity Hospitality Services at Trinity Health. In his position, Billy provides direct leadership to the service line leaders at ministries in New York, Pennsylvania, Delaware, Maryland, and Florida. He provides strategic support and coordination, driving standardization and consistent processes across Trinity Health. Mr. Fisher also oversees the Trinity Hospitality Services Environmental Services Advisory Council Committee, which supports in defining systems and uniform tools that drive excellence in environmental services. Mr. Fisher holds a BS in Business Administration and Operations Management degree from California State University, Long Beach. So with that, I will turn that over to our presenters today. Welcome, Billy and Dr. Carling. We're excited to hear from you today.
Thank you. Thank you very much for the very nice introduction. And welcome to all of you. Good afternoon and good morning. And thank you also, as before, for taking your time to listen to this presentation. I believe it's an area that is broadly interesting to healthcare in general, and I think we have a lot of interesting things to share with you, and I hope questions that you might be interested in asking. We've been presented as to who the speakers are. Our objectives are straightforward and basically to focus on the patient health benefits as well as the hospital savings for implementing a structured program for C. difficile mitigation. Everybody that's on today's meeting is well aware of the fact that the hospital environment and managing it and cleaning it has been considered fundamental as an intervention for healthcare prevention by everybody and documented by the CDC many years ago. Today, we're talking about specifically C. difficile infection, which continues to be a major problem. There was a slow drift down over the past decade, but it hasn't by any means impacted in a large way the incidence of C. diff in U.S. hospitals and hospitals in many other parts of the world. In fact, in the United States, we're seeing continuation of this terrible problem of C. difficile transmission, with one death occurring about every 30 minutes due to the disease in the U.S. How have we been trying to mitigate this problem in the past? Well, back in the 1980s, when C. diff was first discovered, it was noted that there were outbreaks and clusters of patients that would get C. diff, and the environment was implicated rather quickly. It was also realized that only one disinfectant that could be used in hospitals was effective at killing C. diff, and that, of course, as you know, is our excuse me, is our only sporicide, and that's bleach that was available at the time. The recommendation from the CDC was to use bleach in those rooms where C. difficile patients are treated. And this is what we've been doing since about 1987. The problem is that over the past decade, we've learned that we're only talking about the tip of the iceberg. We believed that the patient with C. diff was the major problem. We now know that although important to take care of these patients in a focal and environmentally safe way, they are not the major cause of transmission of C. diff to the hospital environment and to other patients. We're not going to go over this in detail, but these are the data that have shown me and others how important the asymptomatic patient is. Turns out that number 1 and 2 there, approximately 10% is the number I keep in mind of people that are in acute care hospitals harbor C. diff in their GI tract and can spread it. These are asymptomatic people without diarrhea, but have C. diff colonization. It's also been realized that these folks spread much more C. diff to their environment if they have any exposure to an antibiotic. That increases from 10 to 10,000 times more spread from the GI tract due to any exposure to antibiotic. And of course, 70%, as everybody knows, of patients that are admitted to acute hospitals get an antibiotic at one time or another. That antibiotic stewardship has decreased that somewhat, and the duration of treatment somewhat, but still lots of folks obviously need antibiotics. And it turns out that they shed into the environment their C. diff, which of course is not being directly attacked by the approach of cleaning patient rooms who have had recognized have having C. diff with bleach. In fact, it's even been recognized that if you go to a hospital bed or admitted to a hospital bed, and that bed was previously occupied by somebody with C. diff, previously occupied by a patient who got antibiotics, you have an increased risk of getting C. diff because that patient having a chance of being asymptomatically colonized. This study included about 200,000 patients in New York a number of years ago, about 5 years ago, and is rather, I think, sobering and explains a lot about why we haven't been able to control this infection by the approaches we've been using. So what about the new approach? New approach is based on the concept of horizontal interventions. Horizontal interventions in healthcare infection prevention, as I hope many of you are familiar with, are things that work across the spectrum of prevention, such as hand hygiene and environmental hygiene. We don't have time today to talk about hand hygiene, which is certainly a critical component of healthcare infection prevention, but a very, very challenging one to carry out in the ideal fashion, as I think everybody listening to this is well aware. In terms of environmental hygiene, where we're going to be focusing today, liquid chemical disinfection and physical cleaning are the key elements. We're going to talk about each separately. In order to mitigate C. diff, I believe it's critical to optimize both product use and practice in terms of thoroughness of cleaning. We're going to talk about each of these components and show how they are totally interrelated. First, let's just start off with the disinfectant. Briefly, the message that I hope everybody may be somewhat aware of is that things have changed recently with new disinfectants, many new disinfectants. The one we're going to be talking about today and the class we're talking about today is sporicidal and rapidly sporicidal. You have to be a little bit careful about some claims that are being made out there of some new disinfectants that look like they're sporicidal, but are not really sporicidal or are only slowly sporicidal. So what we're talking about today is the hydrogen peroxide peracetic acid type disinfectants that we'll comment on a little bit more later on. We know there are cost issues with these disinfectants, but I think we're going to be talking more about cost later on. And I think this becomes less of an issue the more we focus on how the value is, what the value is to their use. So let's talk about optimized practice. Quite a number of years ago now, we used a system for covertly evaluating how well terminal cleaning was being done in the 3 hospitals that I had the most contact with. We found out that per policy, only about 50% of the surfaces that were supposed to be cleaned in a patient's room at the time of discharge were being cleaned. We call this percentage the thoroughness of disinfection cleaning, namely the proportion of objects cleaned relative to what the policy says should be cleaned. We were shocked by these results, but then when we went to other hospitals all around the country, infection preventionists used the tool that we developed and found out that most of their hospitals were not cleaning any better than we were. There were a couple that were cleaning fairly well up there at almost 90%, but not very many. And the one hospital down at the side there wasn't really doing any cleaning at all, which is rather shocking, but was repeated and found to be true. On the basis of this kind of information, and it was only logical to make an intervention to correct this and to improve this situation. And so we developed basically a 3-step approach in which you'd evaluate covertly the cleaning that was being done, as we did, I just showed you in those hospitals. We then would take, and the hospitals would take and implement education for their environmental services staff, as well as feedback, serial feedback. In other words, going back and rechecking how well things are being cleaned on a repeated basis. This modeling, very straightforward, has been used now in thousands of hospitals around the country and around the world, and is pretty straightforward. The tricky parts of its implementation, Mr. Fisher will be discussing in a few minutes in terms of the details. The recognition that all hospitals were not being very well cleaned and that could be sustainably improved upon by such a program led in December 2010 to the CDC developing some guidance for this monitoring of environmental cleaning. The reference here is noted in your handout if you're not familiar with it. It's a straightforward document. It hasn't been updated, but when I last discussed it with the CDC, there were no major changes, although they recently eliminated the ATP tool as a recommended tool for evaluating environmental cleaning in hospitals. So that is a change, but it has not changed in this document. It changed in their most recent documents on cleaning. The system that is described as elements, which I won't go into today, but are very critical in terms of their structure. It's not something, these tools, to use the fluorescent marking tools such as we used, can be done very casually or can be done in a structured format. And I believe very strongly, and I think the data you'll see today will support the structured use of these tools. This is what happens in hospitals that use such a program in terms of thoroughness of cleaning. Hospitals is a group of hospitals in Iowa. And as you can see, the hospitals varied fairly widely, as the group I showed you earlier, in their cleaning at baseline. With phase 2, meaning just education, it improved, and with repeat feedback, it improved more. The one thing you'll notice also about this slide is that the number of hospitals participating in this evaluation program decreased over time, and that was because of the challenges that ICPs have in trying to maintain new programs and the dedication needed to do such, which is one of the important parts of the story we're going to be telling today. It's also very important to realize that this data was achieved without extra personnel. It was resource neutral. This has been seen over and over and over in our studies over the past 15 years. It doesn't take more people to do the work to clean better in hospitals. It just takes feedback and helping people do a better job by showing them what they're doing. This is best illustrated by a study that just was published last year, a hospital in Connecticut, where they used this program. And you can see it took a little bit of time. When they first implemented it in 2011, it went up and down a bit. It went down, that point where it went down here, let me see my arrow works. Here's my arrow. This area here where it went down after improving was due to the fact that the program itself was turned over to non-infection preventionists, and the program sort of slid away, and it wasn't realized for a while that cleaning had fallen off because it really has to be a validated program. It's difficult to be evaluating yourself. So we've always encouraged the environmental services management to utilize infection preventionists or other surrogates to separately and independently monitor cleaning thoroughness. The key element to such a program is now going to be discussed by Mr. Fisher.
Thanks, Dr. Carling. I appreciate that. Yes. So how does this all work? Well, the dreaded word, change management, that can just draw fear in us in the healthcare world, right? Just in general in society. I think, though, in general, the last few years post-COVID, I think that is became more of a positive approach because all of us on this call at some point or another have had to make changes on the fly, for the betterment of our patients, the safety, and our institutions. With all that being said, it's still important to understand when you're looking to possibly do a change that you have all the key people in place to be reviewing that. You take a look just in our society today as far as change management, information that's being thrown out there and the back and forth on as far as what's happening today. I mean, if you think about it, we talk about our main mode of transportation today, right? We talk about change management. Everybody's all worried as far as the reliance on fuel and what are we going to do as the years go. And well, I've had this for so many years. I've been driving my car. I've had the same for the last 30 years. I can't change. Think back to the 1800s and before, and the early 1900s before a car came around. What happened? How did everybody get around? Horses, right? So imagine back then if what the thought process was of, I have to go away from my horse. No, I can't do that. What's going to happen? You're going to get left behind. So you'll always have to be open to, those discussions as far as, trying to bring as many of the facts as you can to the table, and then also bringing the folks in from the different departments and things like that to talk through what they might have a different point of view or feedback on what, a particular project is that you're working on. Dr. Carling had a quote, there from, a musician back in the 60s about changes to come in Bob Dylan. Another one just is like, if this is from the former President John Kennedy, change is the law of life, and those look only to the past or present are certain to miss the future, right? So it's so important that we're always continuing to look to that future and to try to better ourselves for our patients. So When we were looking at this, as said in the beginning, Rhonda had mentioned a part of Trinity Health. Trinity Health is a larger system, 60 plus hospitals throughout the country. We had been working on this for 7+ years. So when we were setting things up and going through this process and what we were going to do, we had a lot of input, not only from what you would call our system office colleagues, but also the local hospitals, making sure infection prevention, nursing, quality was all part of those discussions when we talked about what chemical we were going to use to make sure that our patients and visitors were safe. So we looked at it from a macro level, but then we also looked at it, in the minutia down to each of the ministries. So as we did that for each of the hospitals, what was the current hospital culture? What was the willingness to change? What was the support behind it? So understanding those things we need to do at each of those facilities over these past 7 years, we really had an oversight committee that looked at what the best process was for us to move forward, and is this the right approach? So obviously that collaboration through EVS, administration, infection control, nursing, HR, human resources, and employee health, they were all part of those processes. And I will tell you, I wasn't part of all 60 plus, but probably the 25 that I was personally, there was a lot of different questions, a lot of different discussions, and each of them have only made us better the implementation, but then thereafter as far as managing the performance. So we really tried to make sure that we set up things really strategically to make sure that everybody knew what the plan was, and ensure that did we have to make changes, or are we going to move forward? Those of us, I've been guilty of it through the years. Whether it's through environmental services department or other departments, a new process or something gets implemented and changes, and then you get in a leadership meeting like, what's that? I never heard of that before. That's new. When did that start? Oh, last month. Oh, great. So, we tried to be deliberate as we've through the years, and we've got a lot of lessons learned over these 7+ years. Dr. Carly, you can go to the next slide.
Oops.
So again, as we set up these committees, a lot of the FAQs that we had from the beginning, and then we really kind of structured the beginning of those committees and the things we discussed, as far as the why. Dr. Carling obviously talked a lot about that in the beginning, and he'll piggyback off once I'm finished and talk about it some more. What the reimbursement is, what the financial impact is, for each of the hospitals, and then the organization as a whole. The time frame, the rollout. Obviously, we kind of created a blueprint that we would have, but we altered it, at each hospital. So we did that and tried to do that strategically. And even some of the ministries, the hospitals that we didn't even roll it out completely all at once. We rolled it out in stages. But whether we did it all at once or we did it in stages, we're able to make that a positive rollout. So as you can see there, again, we didn't always roll out to that last bullet as far as each of the ministries. So thanks, Dr. Carly. Next slide. Operationalizing the program. So obviously one of our key elements is obviously the vendorship partnership. So obviously whether it's with Ecolab or another vendor, ensure that they are true partners, right? That they're going to see that process through. And that was important for us as we made those decisions, to ensure that they were going to have a seat at the table, which they did throughout the process. So our vendor, so we had Ecolab, that they were there. They were part of all 60 plus calls and subsequent calls and the training afterwards. So it was very beneficial for us that they were part of that team. A lot of group training, one-on-ones, especially when it comes down to the end users from the environmental services technicians that are out there in the field, is really making sure they understood the why, understood even into the detail as far as what the chemical is and how it's utilized. It's important. You got to have the knowledge behind what you're using, whether as a doctor, whether as a nurse or frontline EVS tech. It really got to come down and make sure they have that knowledge. And as we went through and started to do these rollouts at each of the ministries, is really keeping it front and center. So, for us, it's the first thing that's the most important is as we roll these out unit by unit, is we're celebrating. We're celebrating the recognition as we move forward and start to see results through the hard work on the front end. So we would make sure not only that we recognize the EVS colleagues, but we would report back through our infection control meetings at each hospital, making sure that the nursing units were recognized as well for their support, because that plays a big part in what we're doing. So that's hugely important. So we're able to actually monitor the cleanliness from our EVS management team and staff. So it works very well. Next slide, Dr. Carly. Okay, so some of the keys to success that we set up as far as blueprint is to kind of keep everything up front and center from our standpoint, from an EVS cleaning perspective, is making sure that on our huddles. So every day the teams huddle up in the morning, in the afternoon, and also on the overnight shifts, giving key pertinent updates within the facility or within the department specifically. Well, at least once a week, what we do is we do update the performance as far as that we get back as far as from the cleaning standpoint. We do monitor through a glow gel testing system where we do monitor the actual performance as far as the cleaning of the high touch areas that work really well. And then we filter that into an online dashboard that we have online that so through support of Ecolab. And that actually information not only gets reported back and accountabilities are set up with our EVS team, we also report that again into our infection control committees across Trinity as a whole. So our performance reviews, not only the department itself, but the individual, and as I mentioned, the infection prevention committee and benchmarking. And it doesn't matter whether it's one hospital or it's a multi system. I mean, being able to benchmark and compare is greatly important and really helps with as far as action planning too. If you have areas of weakness and things like that, you can really identify those, and it's easy to put plans in place to try to correct those. And then through what we do now, we also have that in our annual competencies for our frontline EVS technicians. So how to utilize the chemical, all the high touch cleaning surfaces and things of that nature, that's all part of the annual competencies that those technicians go through each and every year. Okay. And this is just a little bit of a screenshot of the dashboard that we utilize. So you'll see in the bottom right with the facility performance. Now, this is from a little bit ago, but you'll see, this isn't all of them, but this is just a few of our hospitals throughout the country, and you can see the overall score and the audits that are conducted. We do a quarterly target for the glow gels that we do. So that's all based on bed size. So we'd have a quarterly target off of bed size. So it helps with us as far as an apples to apples comparison, because if you have a ministry that has 50 beds, but they're doing 100, that can skew the data a little bit. So we try to be consistent as far as making sure the quarterly targets are hit. And also this, what's really great is you can really, drill down and see more of the data. So if there's an area of struggle, like for example, a lot of times the overbed tables within patient rooms can struggle, or the call buttons, which obviously both of those can harbor, C. diff greatly as far as they come in high touch. So we make sure that we're able to identify what our areas of struggle are, and we try to focus in on them. So just a little bit of background. Again, we're really deliberate as far as the approach, and we're always looking to try to make sure we're looking to the future and what we can continue to do better, and that's what the focus is. So all right, Dr. Carling, I think it's back to you, I believe. Yep.
Okay. Thank you so much, Billy. We'll come back to some more of that Trinity data a little bit later. So given the background that you've heard in detail, we set out to evaluate the possibility that C. diff could be mitigated based on an approach that utilized daily cleaning, not just terminal room cleaning. It was optimized by feedback, as previously discussed and as mentioned in detail by Billy. And the program was hospital-wide. It was using a sporicidal cleaner that could be cleaning chemical that could be used every day on every surface in the patient zone. The results of the study I'm going to show you now were published online last summer and published in the March issue of Infection Control and Hospital Epidemiology in the hard copy, and are available as a free download online as open access. The implementation of this study was available sites within the Trinity program that had stable rates, and this is very important, stable rates of C. diff, because many studies over the years, infection control in general, and C. diff in particular, have been involved in situations that were really outbreaks or very extremely high rates of C. diff, clusters of C. diff. And while they're important to know that such can be controlled by interventions, it really doesn't have any meaning on a day-to-day basis without having studies that look at stable endemic situations. The cleaning was covertly evaluated without the program, without the individual line workers in the Environmental Services Department being aware of what was being monitored. And so their cleaning was baseline cleaning, was objectively assessed. And the elements of the intervention were implemented concomitantly during a wash-in period. Each hospital had a wash-in period that I'll show you, that where data was not collected, but education and the programs were implemented. The hospitals involved were scattered around the United States. They varied in size from small inside the boxes, the size of the hospitals, from relatively small to quite large. The programs were implemented independently over about a 1.5-year period, mostly in 2017. And it was during a period of time that these hospitals were stable in their epidemiology for their patient mix. As noted at the bottom, there was no real change in the Medicare case mix index or the length of stay in the hospitals. A disinfectant, as mentioned previously, is a hydrogen peroxide, peracetic acid disinfectant. And it's also interesting to keep in mind that it's a very effective disinfectant for other tough pathogens, such as C. auris and norovirus, as well as essentially all other bacteria that are involved in healthcare-associated infections. The program itself was consistent with general guidelines that have been out there. In other words, who's cleaning what and how much and how frequently, et cetera, were utilized the typical resources in this area. Pre-intervention results. The hospitals, the 8 hospitals in the group, their overall thoroughness of cleaning was about just under 60%, which again is the number that keeps coming up over and over. In fact, when we've done studies around in Europe and in Australia, hospitals in cities and the places that we're able to study in those locations, again, had cleaning rates just about 50 to 60% in terms of what was done versus what was expected. In terms of C. diff, over the 18 months prior to intervention of the study, C. diff rates were noted by the black dots at the average for that time. This is we monitored the hospital onset CDI rate using the SIR rather than raw numbers, because the SIR corrects for severity, as I think all of you probably know. The SIR 1 is the national average C. diff rate for all hospitals. A hospital is 40% above there. 2 of them were relatively higher and a number were lower. But over time, you can see the blue line really didn't vary significantly from one over the period of 18 months. So that's the endemic rates are stable. So post-intervention, once the elements of the program, that is the feedback system, the education, and the daily use sporicide were implemented, the thoroughness of cleaning rapidly improved. We've seen this with every hospital that we've ever studied, a few thousand hospitals now. As soon as you give folks objective feedback as to what they're doing, they really rapidly do a good bit better. These folks are motivated. They're caring people. They just haven't been given the opportunity to understand sometimes exactly what is expected of them. So the improvement is rather striking and rather rapid. In this study, in these 8 hospitals, you can see that a couple of hospitals lag behind there in terms of improvement, but rapidly improved. And by the end of the total intervention, everybody was well over 90% thoroughness of cleaning. And this was a very stable figure during the last year of the intervention that was being monitored. What happened to the C. diff? Well, immediately on improving the environmental hygiene, the C. diff rate measured by the SIR decreased about 40%. With continued improvement in cleaning over the next 18 months, the C. diff endemic rate in these hospitals went down, and again clustered fairly tightly by the end at about what looked like a 50 to 60% improvement. But we had also, aside from these 8 hospitals, we had a group of hospitals, 9 hospitals within the Trinity group that had not implemented the program and were monitored. It turns out that, and epidemiologically, they were by chance very similar overall average on the group. The group's average, the controls versus the implementation hospitals were very similar. So against that group, because there was a slow and slight decrease in C. diff during the study period in those control hospitals, the overall improvement, I think, that can be garnered from this information from this study was that there was about a 50% decrease in hospital-onset C. diff on the basis of the study. Many confounders were evaluated and not found to be contributing, such as changes in hand hygiene rates and things like that. We evaluated many other potential confounders and did not find any other explanation for the decreased rate. Billy, you might want to comment on the implementation and how it's affected the hospitals that were involved in the Trinity program.
Yeah, we've seen such a decrease over the years, as you can kind of see there, and continues even through the COVID years. Been very pragmatic, as I was mentioning before. So the amount of cases that you could just it speaks for itself as far as the trend, and that's each of the 60 plus facilities throughout the country. So this gets reported up through the system, and then out to each hospital. So some great results and continues to this day. So
thank you. Oops. So what about the resources for optimizing your program at your hospital? There are very clear and I think well-detailed resources available that I'll just mention, and the references to them from the CDC are as noted. They really do point the way forward in this whole world of improving environmental hygiene and optimizing it in healthcare settings, particular acute care hospitals. These are the core components that the CDC is highlighting. Each one of these in their documents has a great deal of detail within it. It's also been, this whole issue, this whole area has now been recently addressed by the new compendium, the C. diff compendium just published this month with SHEA IDSA APIC guideline. The introduction to this rather substantial document, which is an update of the 2014 guidance for C. diff mitigation. It highlights 3 essential practices. First is antimicrobial stewardship. Most hospitals in the country, in fact, essentially all hospitals in the country, are doing antimicrobial stewardship and hopefully are continuing to improve antibiotic use. So that's an understood and accepted approach. The second one is diagnostic stewardship, and that means ordering testing for C. diff correctly on patients, not over-ordering it or under-ordering it, and doing it expeditiously in patients that might have C. diff, et cetera. Those policies have been pretty well promulgated in most hospitals in the last 4 or 5 years. Finally, the notation that assessing the adequacy of room cleaning, an additional approach in 2014 compendium, is now considered an essential practice recommendation. The assessing the adequacy, that's the monitoring that we've been talking about in the program we've been talking about. This doesn't address the disinfectant, except to say they expect sporicidal disinfectant to be used as appropriate. Additional evidence for the impact of this program, besides what I've just showed you, completely separate from anything I was aware of until 2020, well after we had finished collecting the data for the 8 hospital study that I just showed you. A group of researchers at the University of Wisconsin, directed by Dr. Mazia Sadvir, did a modeling study to look at what possible interventions would affect and mitigate C. diff in a hospital. This is a modeling study based on using the medical literature, several hundred references that they used to quantify various aspects of the interventions that are talked about to help mitigate C. diff. And they modeled it on a 200-bed hospital with an average C. diff rate with this SIR of 1.0. They found their data was displayed this way. If you look at this slide, the 0 here is the baseline. That means before any intervention. And what's shown above and below that 0 is this is the amount of money the intervention costs the hospital per year, and this is the amount of money the hospital saved per intervention for the year. And so, and this here is the impact in terms of C. diff infections averted. Oops, excuse me. Sorry. C. diff infections averted during the year. And as you can see, there were some interventions, for example, some visitor hand hygiene and things had a cost, but no discernible benefit. Visitor contact precautions, for example, patient hand hygiene. It had maybe a little bit of an impact and maybe a little bit of a savings. Here's where terminal cleaning, which is what we've been doing, terminal cleaning with sporicide, as you can see, it had some impact. That's not surprising, but unfortunately, that impact is the kind of impact that is only limited, as I mentioned before. The hand hygiene does have an impact and saves money, as you might guess, and did prevent cases in their modeling. But the most impactful intervention was daily cleaning. Hand hygiene level that they used in this modeling study was about 75%, if I recall correctly. Daily cleaning thoroughness was a little bit above 80% due to the feedback type of program that they utilized in the modeling, and the same as we've been discussing. In their model, they averted 25 cases per year, a substantial number of cases in their 200-bed hospital. This study, the study I just showed you, was recently, in fact, just 3 weeks ago, reported, the group reported, I should say, an evaluation of how their modeling study, which again is a hypothetical study, how that was reflected or not reflected in their experience at the University of Wisconsin Medical Center over a number of years. And what this slide shows is the 2 points, and that is the actual rate and the dashed lines. They used the raw numbers here, the rate of 12, basically 12 to 13 per 10,000 patient days in the pre-intervention period, 2015, 2016, when they implemented the program at the hospital of the feedback and the sporicidal daily cleaning. They saw the rate drop as they predicted it would have using their modeling study down to about a 60% improvement over baseline. Their rates at being a large hospital, most large hospitals have somewhat relatively higher rates, even corrected with the SIR, but that's why you use the SIR, is to correct the rate. But for an individual hospital, it's perfectly acceptable and reasonable to follow absolute numbers as long as the admissions stay relatively the same. So basically, the modeling study has been validated, I think, in a very elegant way, and the paper is available on PLOS ONE with open access for anybody that's interested in looking at the rather complex details of what they did. So let's now move on to what we've sort of been waiting to hear more about, and that's the whole issue of the cost of such a program. I think it's easy for any of us to accept the value in decreasing C. diff rates in our hospital and transmission in our hospital, but everybody has, there's a cost to everything. But it turns out the cost of hospital onset C. diff is a little more complex than it might appear to be, because reimbursement through the hospitals that have Medicare reimbursement, essentially everybody except for the closed system hospitals, VA system, are reimbursed for cases of C. diff. If you have a patient that acquired it in the hospital, you get paid back more than you would for a patient that didn't. But what people had not realized until these studies had been done, these very recent studies actually, is that there was a cost that was the total attributable cost per case, but that not all of that cost was reimbursed. And so what turns out is that per case of hospital onset C. diff is a non-reimbursed cost per case that was evaluated by these 4 studies that evaluated different parts, but the results I think are rather strikingly similar. If you look at the 3 hospitals that did the assessed total attributable costs, and this is using Medicare and other data of hundreds of thousands of cases of C. diff. These are very, very large studies. And basically the total cost per case was around $28,000. You can see the similarity is rather striking. The data is from roughly 2015, I would say. On average, I'd call it 2015 overall. In 2015, this was the total cost of thing, and this is, oops, excuse me, and this is how much it was reimbursed. This is the non-reimbursed cost was $14,000 and $13,000, and the 2 studies that assessed that, this study didn't look at the total cost, but came out the same. And I think, to me, the symmetry of these results is very striking, and I would basically say that they have shown that the cost of a C. diff case is, to the hospital that's not reimbursed by third-party payers, is about, well, $13,000, let's say, I'd say $15,000. Let's round it off. This is 2015 figures. You can use inflation if you want to get fancy and add to it, but that's a rough number to think about in terms of how this implementing such a program might affect your hospital. So how did it affect the Trinity hospitals that were just shown? Well, there was a distribution. The hospitals over here, the bed sizes, as you can see noted, these are medium-sized hospitals. They did not have much savings of money. Why? Because their C. diff rates were very low. Their SIRs, those are the 3 hospitals that had SIRs around 0.3 to 0.4. And therefore, actually, in these hospitals, they decreased their cases by only 1 or 2 a year, and so their savings was very low. In fact, one a year in these 3 hospitals. So they didn't save much money, but they didn't have much of a problem to begin with. As soon as you get a little bit more higher rate of C. diff in a medium-sized hospital, it looked like this. Whoops. And as you can see, the larger the hospital, you're going to save more money. But these hospitals also had relatively higher. Those are the ones that, if you remember from the data that I presented as the pre-intervention data, there were a number of hospitals above the SIR of 1. These hospitals were above 1, and their savings per year of cost avoidance in the situation of not having the C. diff cases was about $500,000 a year. So that's quite a wide range between maybe $15,000 a case, one case, to many cases up here at $500,000. For your hospital, it's obviously pretty simple to figure it out in terms of what you could accomplish. So if you think about it, it would be possible to calculate or project what you might believe could be your savings. For example, if you had not implemented the program that we've discussed here and wanted to implement it, you could say, well, maybe we won't be able to, in the first year, achieve 50% decrease in our C. diff rate, but maybe we can decrease it by 20%. So, okay, so if we had, 20 cases a year and we thought we could decrease it by 20%, that would be 4 cases. And so you can see what your savings might be. If you are only decreasing at 4 or 5 cases, you'd be saving not very much, under $100,000. If you have a larger hospital and have larger cases, and you think you can decrease by 15 cases, you could save $200,000. You can project this savings very, very simply based on your own data. And I think realize the cost benefit of doing better with C. diff. So that's the conclusion of my structured comments. I've probably raised, I hope, some questions. Thank you.
Thank you, Dr. Carling and Mr. Fisher. That was an excellent presentation. We've had lots of questions coming through the question and answer pod here, and Mr. Fisher has been graciously answering those as we typed along. Do you want to speak to any of those questions, Billy, in the greater group setting?
Yeah. I mean, we can. The one question was what post cleaning inspections are performed, and then there any incentives. So yes. So if I just to touch on that a little bit more. So there's a certain, obviously matching up, as I was talking about, there's the quarterly target that we use at each hospital depending on bed size. So the leadership team with environmental services will do unannounced audits. So as they get a room, a patient room, what they'll do is they'll go up and mark it ahead of time. That frontline staff member will not know which room that is. So on average, we're marking 17 surfaces during that audit. So we'll just use the glow gel marking system. So we mark each of those areas, and then once the room has been cleaned, we'll go back and do an audit of the ones that were clean, and if there's any that were missed. And then from a recognition standpoint, we kind of just call it the 100% club. So we post it on a lot of our huddle boards that we have in the departments, and then our monthly staff meetings that we conduct as well. And then depending on the hospital, it's not everyone, but we try to, if we can, do a small cafe coupon that we do. But I think most importantly, it is part of the annual review. So anybody that is a part of that cleaning, it's part of those KPIs that they get graded on. So that can have an effect into what their annual merit is, which I think is important to try to recognize them from that financial aspect as well. So that's that one. Next one is about antimicrobial stewardship program. Yes, infection prevention has had a robust program these 5+ years, and has been doing that consistently as well as what we're doing from an environmental standpoint. High turnover was a question about high turnover when we've seen an effect. Yes, we have. I mean, I can't lie. There has been pockets, whether from the frontline workers or you have leadership turnover. We've had, when the pandemic first hit, I mean, our turnover environmental services, I think, jumped to like 45% in some areas. So that was huge. A great operating program, engaged program, you might see less than 20% is like a really good number. So that obviously was a huge number for us. So we did see it. The one good thing is, we're able to see it from a macro. So if we start to see a slide, we're able to get an action plan going a little bit quicker, so we can see that data full time, whether it's the scores itself or the audits are not matching up to what we need to be doing. So that was another one that I answered, and I think that's what did I miss anything around? I think those are ones.
No, I think that's great. I wanted to bring those out in the greater group setting in case people missed them, because I thought those were great questions and some great points to be brought out. A few other questions that have popped up into the chat here. One about laboratory testing. So there was a couple questions about testing protocols. What's the standard for lab testing for C. diff to identify infection versus colonization? And also, was there any impact or consideration to laboratory C. diff testing methodologies?
That's multiple questions together. Laboratory testing, the recommendations, most current recommendations are in the new compendium, if you want to double check those and compare what your hospital may be doing. There is no recommendation for testing for asymptomatic patients at the present time. That's been evaluated, and it turns out that, in other words, testing and isolating patients as they are admitted to the hospital is a very expensive intervention, as you can imagine. It also raises some ethical issues about how you manage somebody who feels fine and has C. diff in their GI tract. And so that's not being done widely. And there is no test that can separate symptomatic from asymptomatic patients. It's the patient that you're evaluating, that you're testing on, one way or the other.
Great, thank you. This was an interesting question. Are there any incentives that have worked for prescribers for antibiotic stewardship?
Not that I'm aware of. The stewardship implementation has really been very valuable. But I think for many reasons, in particularly decreasing the pressure on evolving antimicrobial resistance, the impact on C. diff itself has probably been, if not realized by the good programs already, I think probably somewhat maximized. We can't go back, but I don't know that we can do much better in some hospitals than is being done in terms of stewardship, period. I should say, as a means for decreasing C. diff, period.
Okay, and just a general question that I think is great to bring out. One question that came across prior to the presentation was just how long can C. diff live on surfaces anyway?
We're still waiting for the ultimate test. People got bored after about 5 or 6 months of spores surviving on a dry surface. I would say it's indefinite. Nobody really knows. It's at least 6 months to a year.
Wow.
They're extremely resilient, and the infectious dose is also very low. It doesn't take much to get it. If you're a healthy person, we all are probably getting C. diff spores into our system from time to time. In fact, they're in the environment, they're in animals that don't seem to be the cause infection in humans in most cases, although there have been situations that C. diff from animals have caused C. diff in clinical C. diff in patients. But these spores are very resilient. It doesn't take many of them to cause an infection.
Wow, sobering. A quick question about whether there's been any data about how the pandemic has affected C. diff transmission rates with hospital overcrowding, just difficulty just with the shortage of healthcare workers and support staff workers in general. Have we seen a change in the trending of C. diff infections post-pandemic?
Excellent question. The answer is, and this has been reassessed just as recently as a few months ago, it's been variable for hospitals. Overall, there hasn't been a national change very much because there's sort of two different offsetting factors. One, as you point out, is of course the increased hospitalizations and the very sick people. But on the other hand, people were also on isolation, and the cleaning that was being done was incredible. Turns out that the cleaning is important, but for COVID not so much, because COVID does not live well on surfaces, fortunately. But we didn't know that until well into the pandemic, and so a lot of vigorous work was being done with cleaning and with isolation, which in some hospitals decreased the rates of C. diff. In other hospitals, they were the same. In some hospitals, they increased. But overall, they're actually, I think it sort of neutralized itself.
Interesting. Okay, well, we are at the top of the hour. There were lots more questions in the chat. We'll try and get some responses to those for you and get those posted. But I just want to thank you again, Mr. Fisher and Dr. Carling, for this excellent presentation. Had lots of interactions, lots of participants for this. So obviously a very important message to get out. So want to thank you very much, not only for your time today, but the time and effort that you have put into this subject for the betterment of us all in healthcare. So thank you very much for being a part of today's presentation, and you will be able to, in a few days, access the webinar recording as well as the slides. You can find those on the AHA Team Training website. So have a great day, everyone. Thanks for your participation.
Thank you. Thanks, everybody.
Thanks so much.